feeling like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. And I'm right where I belong in my happy place. And I'm right where I belong in my happy place.
Hello and welcome to the National University of Singapore Yong Lu Lin School of Medicine's Healthy Longevity webinar. It's great that you're here. Thanks for joining us. We have a great talk tonight by Heike Bischoff Ferrari, and I want to remind you to use the Q&A function to ask questions, and we will get to as many of those questions as possible. I just got back to Singapore from California, and I did an experiment I want to tell you about. So I went for a 2-mile hike in California in Joshua Tree National Park, where it was 45 degrees Celsius. And then when I came back here today, I went for a 2-mile walk in Singapore where it was 35 degrees Celsius. And I can now say I have validated that Singapore is worse. The humidity here is really difficult. So just letting you know that I'm still doing science in addition to my role as a host for the webinar. Before we go on to Heike, though, I want to introduce Guan Shoping, who's a senior research fellow in my lab here at NUS, and he'll be talking about the mechanism of FUDR-induced lifespan extension in C. elegans.
Hey, thank you. Hello, everyone. As mentioned, I'm Soping from Prof Brian Kennedy lab. Today, I'll be sharing an exciting insight from our recent work on the mechanism of FUDR-induced lifespan extension in C. elegans. 5-FU, or its derivative FUDR, is a well-known chemotherapeutic drug. Inside the cells, FUDR will inhibit the synthesis of thymidine and therefore stop DNA replication. In C. elegans lifespan study, FUDR is widely used to stop the egg from hatching and allowing for a synchronized adult population, which is critical for lifespan study. And under standard monoxic condition, is generally regarded as a benign treatment with minimal impact on C. elegans lifespan, as shown by early study by Mitchell and Hosono et al. However, this is not always the case. When C. elegans are exposed to non-standard conditions, such as in hypertonic stress or elevated temperature, FUDR actually produced a remarkable effect. It significantly extended lifespan and enhanced stress resistance. The story became more interesting in specific genetic mutant. For instance, the GAS1 mutant, which is defective in mitochondrial complex 1, FUDR treatment actually nearly double its lifespan. And more critically, this effect appears to be independent of the germline disruption, as FUDR also extends the lifespan of GLP1, which is a steroid mutant. So beyond this mutant, similar longevity effects are observed in worms with targeted genetic perturbation, including RNAi knockdown and transgene overexpression. So this consistent pattern suggests that the FUDR impact go far beyond just simply sterilization. Because of all these different observations, there are several mechanistic pathways that has been proposed to explain FUDR-mediated lifespan extension. And this include the DNA synthesis inhibition, which trigger the replication stress response, and also stress homeostasis, which activate cytoprotective pathway like the DAF16, sirtuin, and DNA repair mechanism, and also the proteasome and detoxification pathway, which engage SKN1 and GSD24. And it may also involve microbial metabolism, as it modulates host microbe metabolic dynamic under extrinsic condition. Yet, despite all this insight, not a single unifying mechanism could account for all observation. However, intriguingly, our detailed analysis reveal a consistent trend. That is, worm with compromised mitochondrial function, especially those with defect in mitochondrial protein like GAS1, respond most robustly to FUDR. This point toward a central role for the mitochondria. So two key mitochondrial pathways are emerging as a potential mediator based on our observation, and they are the mitochondrial stress unfolded protein response pathway and also the insulin IGF-1 signaling pathway. So we hypothesize that FUDR enhance cellular resilience in metabolically compromised system by activating the conserved mitochondrial stress response pathway. And this insight could be the missing link that unified all previous observation and may lead to new therapeutic strategy in aging research. So we are actively investigating this hypothesis, and we look forward to sharing more details results in our upcoming publication. So if you want to know more, please stay tuned. Thank you.
Thanks, Xiaoping. I want to move forward and introduce Professor Heike Bischoff Ferrari, Chair of Aging Medicine at the University of Basel and Acute Aging Medicine Felix Platter in Switzerland. With a background in internal medicine, geriatrics, and public health, her research focuses on healthy longevity. She leads major international efforts like the Do Health trial and serves on global boards, including the World Health Organization Consortium on Healthy Aging. The title of her talk today is Do Health and Vital, Trial Findings, Evidence for Two Practical and Scalable Supplements Addressing All Three Metrics of Aging. Heike, thanks for joining us.
Thank you. Thank you for having me. Thank you for the introduction, Brian. So I will just jump in and share my slides. Here we go. So yes, I will talk today about two landmark trials on healthy longevity and how they address the three metrics of aging. And I would like to start with explaining to you what we understand under the three metrics of aging. So there is one metric of aging called the biological aging. This is sort of the first level, how we age. And then the second level is phenotypic aging, which is basically the incidence of chronic age-related diseases. And the third metric, often following the phenotypic aging, is functional aging. So when we think about medicine of today, our focus is on measuring phenotypic and functional aging. And medicine of tomorrow and the promise connected to that is coming much earlier, measuring the biological aging processes that come a step earlier at the time when structural changes are not yet implemented or still reversible. So if we think about a strategy to advance healthy longevity, we would like to see that this solution, this strategy is addressing all three metrics of aging. So I would like to introduce to you two trials which are unique in the fact that they were planned as partner trials. So this is on the one hand the VITAL trial, which took place in the US with over 25,000 individuals age 50 and older. And the Do Health trial, the partner trial in Europe, implemented across 5 countries, Switzerland, France, Germany, Austria, and Portugal. And here individuals were age 70 and older. So what is the partnering in this trial? For once, it was the same inclusion criteria, targeting individuals generally healthy without major diseases in the 4 years prior to the initiation of the trial. And also 2 strategies tested were the same. These were vitamin D, 2000 IU per day, and omega-3, 1 gram per day. And to have a placebo control in both of these high-quality trial, individuals were allowed to take the current recommendation of 800 IU vitamin D additionally. Now, this is really key to understand because both of these trials were not about confirming current guidelines on vitamin D, which are mostly focused on bone health. They were really about testing a somewhat higher dose in generally healthy adults, age 50 and older and vital, and 70 and older in the Do Health study. And I will start going into more details on the Do Health study and what we found today, or what we learned today on the 3 metrics of aging. So Do Health had a 3rd intervention, which was a simple home exercise program compared to a sham exercise program, which focused on joint mobility only. So Do Health had a 3-year follow-up, and importantly, only about 2/3 of individuals or 2/3 of the individuals were not vitamin D deficient. Individuals were generally healthy, so we had 83% at baseline who were at least moderately to highly physically active. We had both men and women represented in this trial, and we had all participants were allowed to take the additional 800 IU per day. So here you see the recruitment sites across these 5 European countries, and the intervention dose for vitamin D was 2000 IU per day. The intervention dose for omega-3 was 1 gram per day, and in Do Health, omega-3 was algae-based for sustainability. The main findings of Do Health were published in JAMA in 2020, and I will show you the summary of what we learned so far and go deeper in some of the outcomes. Here you see again the study design, which is also key to understand the message of this study. This was a 2x2x2 factorial design, allowing us to identify the individual benefit of each of these treatments and also the combined benefits with the hypothesis confirmed that there were additive benefits of the 3 strategies. And so what did we learn about phenotypic aging with regard to the effect of these three treatments? So the key outcomes here were influenced by the interventions were the rate of infections with omega-3, also the rate of falls with omega-3, and especially in active older adults, there was a stronger benefit with omega-3. And then we had key additive findings for incident invasive cancer. So this is where we saw this pattern that each of the treatments individually had a small benefit and the combination a stronger benefit. And we have a deeper look into the results here. If you go from top to bottom, you see that the individual interventions had a small non-significant shift to the left, indicating a protection against incident invasive cancer. And then the dual combination, so individuals who had 2 of these interventions over 3 years had a stronger shift to the left, and then individuals who had all 3 treatments through the 3-year follow-up had a 61% reduction in incident invasive cancer. And the explanation is that each of these interventions play on different mechanistic pathways related to biological aging, but also related to cancer incidence. For example, we know that vitamin D reduces uncontrolled cell growth. Omega-3 and vitamin D have anti-inflammatory benefits. And we know that exercise is inducing the apoptosis of cancer cells. So this could explain this additive benefit that we saw here. So now we come to the next metrics of aging, which is very important, functional aging. And here I would like you to see the findings on incident pre-frailty. And this is here listed under functional aging because we used the Fried phenotype, which includes gait speed and other functional measures. And we saw a very similar finding as we saw for the incident invasive cancer. Again, an additive benefit between those 3 treatments, where individuals who had just 1 treatment had a small benefit. It was stronger in the dual combination, and then the triple combination. So individuals who had all 3 treatments over 3 years, they had a 39% reduction in incident pre-frailty. So the next outcome, and this is now preliminary data, this is an effort linked to the Global Healthspan Extension Consortium, which connects 12 universities and researchers in aging to connect, work together, and accelerate our learnings regarding healthy longevity. This is all around using the intrinsic capacity concept, which reflects a composite outcome around the 6 functions that people value most. And this is mobility, cognition, mental health, vision, hearing, and vitality, nutrition. And this is a concept promoted by the WHO and implemented in the so-called ICO program, where these functions are measured and addressed in an integrated way. So in this consortium, we are interested into intrinsic capacity as a key functional outcome, reflecting these 6 key functions that people value most. Also, because publication of John Beard and others have shown that this outcome, the composite outcome of intrinsic capacity, is correlated with current health, and future care needs, and has been adapted also in animal models in geroscience. So I will show you today preliminary data out of Do Health. We built the intrinsic capacity as an alternative outcome out of the 6 functions that were measured over time at baseline 12, 24, and 36 months. And we did see a signal again for omega-3 improving intrinsic capacity over time in the Do Health trial. So this is an indication that a second indication for the functional aging metrics. So then we were very interested into the concept of biological aging, and if these simple strategies influence the mechanisms of the biological aging in a direct way. So we collaborated with Steve Horvath, who developed in a pioneer effort the 1st and 2nd generation epigenetic clocks. And we've submitted this project to the Swiss National Foundation. And the Swiss National Foundation agreed to fund the Swiss participants only, which was a concern because they were the very healthy ones in Do Health. You see here the prevalence of healthy agers by country in Do Health. And you see that both Switzerland and Austria had more than 50% healthy agers without chronic diseases and good physical and cognitive function, as compared to other countries in the Do Health trial, especially the Mediterranean representation of Portugal with just 9% healthy agers. So bottom line, we were concerned that taking those very healthy individuals would reduce our chance to see a signal on the influence of the treatments on biological aging. So before I show you the results, these are the measures that were taken with regard to DNA methylation measures. We measured three second-generation clocks, including PhenoH, CRIM-H1, CRIM-H2, and one third-generation clock, the Dunedin-Pace clock. And in addition, we also looked into the 7 surrogate proteins that build the CRIM or underpin the CRIM-H clock definition, including the DNA-based estimator for GDF15 and other proteins. And I will now show you what we found. So you see here the results of the 4 epigenetic clocks presented in a similar way as I've shown you for incident invasive cancer and incident pre-frailty from top to bottom, the single interventions, the combinations in dual way, and then the triple intervention. And we saw a consistent finding for 3 of the 4 second and third generation clocks, indicating that omega-3 slowed biological aging. And we had 1 clock PhenoH, where again we saw this additive benefit with stronger effects on slowing biological aging if omega-3 was combined with vitamin D and exercise. And when we translated these standardized effects to months of rejuvenation, this was on average 3 months rejuvenation seen in Do Health in the Swiss subset of 777 adults aged 70 and older over 3 years. And these are the findings for the DNA methylation-based surrogate biomarkers for the plasma proteins underlying the CRIM-H clock. And what we saw here was that omega-3 again stood out as an individual treatment, indicating or reducing 3 of 7 of these proteins, including PI1, leptin, and TIMP1. And we also saw again that additive benefit, combined benefit between the treatments for 4 of the 7 proteins, including GDF15, PI1, TIMP1, and B2M in these analyses. And this is the comment by Steve Horvath, that Do Health is the largest clinical trial today showing that biological age can be rejuvenated not only in mice but also in humans, and this with simple interventions such as omega-3. And what is the next step? We want to explore deeper and are collaborating with Tony Viscorai. You may have seen his brilliant publication this week in Nature Aging, where he again validated his proteome signatures of showing the aging process, the biological aging process in 11 organs. He published the first validation step in 2023, also in Nature, showing that based on these proteome signatures, our organs age in different rates, and that in healthy individuals, and that the organ that ages in an accelerated way has also a higher risk of disease in this organ, giving us the opportunity of early diagnosis. And in the recent Nature paper I all motivate to have a look at, he also shows that brain aging may be the gatekeeper for our life expectancy in comparison between the different organs. So the next step, and this is submitted for funding, is we want to see whether our interventions in Do Health also influence this individual organ aging based on the proteome signatures. And now I would like you to show you the same concept in our learnings around the VITAL study. So VITAL was a much bigger study, but less hands-on than Do Health. In Do Health, everybody was seen in yearly clinical visits. In VITAL, 1,000 individuals was seen on site, and the most of the participants, this was a questionnaire-based clinical trial, but also designed for the major disease outcomes which will be captured in this concept. So VITAL tested the same dose of vitamin D, 2000 IU per day, and also the same dose of omega-3 per day, 1 gram. And here the omega-3 source was fish oil, as opposed to Do Health was algae-based. And again, Do Health and VITAL had the same inclusion criteria. Also, VITAL targeted generally healthy adults, but somewhat younger, age 50 and older. And the follow-up was 5 years instead of 3 years in the Do Health study. And also in VITAL, all participants were allowed to take the current intake, the current recommendation of 800 IU vitamin D. So now looking into the phenotypic aging outcomes. So what did we see in VITAL? Sorry, that is, here we go. So a primary outcome, there were 2 primary outcomes in VITAL. One was the incidence of major cardiovascular events. And here the overall effect was not significant, but individuals who nutritionally had a low intake, you know, omega-3 is an essential fatty acid, so we need nutritional sources, especially fish. So people who had a low fish intake, they did have a significant benefit with omega-3 on major cardiovascular events with a 19% reduction. And one of the key events predefined were myocardial infarction. And here, independent of the underlying omega-3 nutritional intake, there was a 28% reduction in myocardial infarction. And here you see the second primary endpoint, which was incident invasive cancer. So here the overall effect of vitamin D was non-significant. However, in the predefined outcome of incident advanced cancer and cancer mortality, there was a significant benefit with vitamin D compared to placebo. And you see here cancer mortality, also a significant benefit with the vitamin D, 2000 IU per day compared to placebo. And you saw a stronger effect if the predefined latency period were acknowledged. So if the 2 first year were excluded, there was a 25% reduction of cancer mortality with vitamin D. And the authors also went ahead and did a meta-analysis across different trials showing, again, a consistent reduction with vitamin D on cancer mortality. So you see already a little bit with the findings from Do Health and now VITAL, the signal is around immune health. And this is also another key finding of the VITAL study, looking at the incidence of autoimmune diseases. So this included multiple sclerosis, rheumatoid arthritis, psoriasis, and many other autoimmune diseases. And this is where VITAL showed an additive benefit. Also, VITAL was a 2x2 factorial design trial to look into the individual and additive benefits of the two supplements. So vitamin D alone reduced autoimmune diseases in 5 years by 22%, omega-3 by 15%, non-significantly, but people who got both supplements, they had a 31% reduction in autoimmune diseases in VITAL. So if we add that, merging these two trials, there is a series of important phenotypic aging outcomes being addressed by these two trials. So we have myocardial infarction, infection, advanced cancer, cancer mortality, and in Do Health, the incident cancer in the additive benefit. So this looks like a profile that we want to see in terms of addressing the metrics of phenotypic aging. So for functional aging, this is an ongoing process. We are currently merging the two data sets in a combined grant application, and VITAL will also phenotype intrinsic capacity. So we will see this data later. And then for the biological aging, there has been a recent publication on telomere attrition. So VITAL measured telomere lengths during the course of the trial. And here again, vitamin D had a significant benefit to reduce telomere attrition over the course of the clinical trial. So in summary, if we pull this all together in addressing with two simple supplements, the three metrics of biological aging, VITAL and Do Health, give a signal. Do Health at this point with epigenetic clocks, epigenetic aging, in VITAL telomere lengths. You saw that there are several, especially around the immune system, addressed outcomes relevant to healthy longevity, cancer, autoimmune disease, infections, and also for the functional outcomes. So for Do Health, we shared with you the preliminary data on intrinsic capacity, supporting a signal with omega-3 in the Do Health study, and the ongoing analysis on VITAL we have to report later. So in order to advance healthy longevity, it is clear that we need affordable and scalable strategies addressing the three metrics of aging. And we propose that based on these two trials, which uniquely were planned as two partner trials, this may be a first example where we can show in the same trials that all three metrics of aging are being addressed. So I would like to thank, of course, especially the Do Health team and participants. And I would very much like to thank Joanne Manson, the principal investigator of the VITAL study. So the next step for these two trials is merging the data and looking at personalized benefits in the strong signals that have been seen in the two trials, and strengthening the functional outcomes where VITAL has a subset of 1,000 individuals and Do Health over 2,000 individuals, and also going deeper in new biomarkers of aging that we will derive from both of the biobanks of these two studies, validating healthspan as a new outcome and also intrinsic capacity as a new outcome, or training these clocks then on these two outcomes of the two studies. So also a next step and with an opportunity to truly work together. You see the Healthspan Extension Consortium, which was built in 2024, and also including the team at Singapore with Andrea Meyer being part of this. See her here. And what we try to do in this consortium is that everybody contributes a valuable data set. And we have so far collected 7 longitudinal cohorts and 10 clinical trials, which we want to use to identify new solutions for healthy longevity, but also validate the novel biomarkers of aging, including all omics that we are interested in to hopefully soon translate to clinical practice. Now I thank you very much, and I'm looking forward to your questions.
Thanks. That was a wonderful talk. It's nice to see large-scale trials like this that can really begin to distinguish the effects of different interventions, particularly things like vitamin D and omega-3, which have had, a lot of variable data in smaller clinical trials around the world. Let's start with vitamin D because, there's a lot of information out there about it. So I want to hear what you think about it. So a lot of people will say you get vitamin D from sunlight. And the bioavailability of oral vitamin D is relatively low. Do you agree with that? And if that's the case, you might expect to see a bigger effect in places like Berlin, where it never seems to be sunny, as opposed to Portugal, where it's sunny all the time. So, what is the story with sunlight versus oral supplementation?
So I thank you very much for asking that, because this is really key to understand also the benefits we saw, and also to address a little bit the diversity of findings around vitamin D that you mentioned. So first of all, indeed, sunlight is the major source of vitamin D because we can produce it in a physical reaction in our skin. The challenge here is that a lot of countries, and actually involving all of Europe, there is not enough sun intensity from November till the end of April. So there is too little sunshine-based vitamin D to cover the needs. And in addition, when we age, we reduce our skin-based vitamin D production about 4-fold. So we need to stay in the sun longer. But of course, there are also downsides such as skin aging, skin cancer, around exposing, taking the sun best possible as a source of vitamin D. And it's also good that you mentioned the Mediterranean individuals compared to Berlin or even Norway in Europe. We actually see that older adults in the Mediterranean have the lowest levels for vitamin D in their blood. And the explanation is that they avoid direct sunshine exposure because it's too hot. They stay inside, go out in the evening where we have very little UVA-B that really produces the vitamin D. And in addition, the whole story becomes more complex by oral supplementation and its dosing concept. So we have recently, I think 3 years ago, published a review called Bolus is Bogus. So what we see as a really a red line through the literature is that intermittent dosing of vitamin D either has no benefit on outcomes such as cardiovascular or fractures, and in older adults, actually increases the risk of falls and fractures, as shown in the Sanders trial with 500,000 IU given once per year, but also other trials. And we have now literature that supports or gives an explanation around this, which is that if you expose your body to very high doses of vitamin D, you trigger countervailing factors that actually reduce the active vitamin D in your body. And we are currently, thinking that the daily dosing is really the way to go, because most likely, as an explanation, and sorry, it's a long
Go ahead,
response.
it's fine.
Because we today consider the cholecalciferol the simple vitamin D that you would have in Do Health or in any supplements, has a half-life of only 20 hours. And this is the compound that most cells can actually take and build the active metabolites of vitamin D. So you want the daily exposure to really get that benefit. And then we also see signals that there is a too much daily dose of vitamin D. So when we look at Do Health and Vital, we see that the 2000 IU in individuals who mostly are not D deficient is probably a good daily dose, because you saw the benefits, but you also did not see the risks. So we did not see side effects of hypercalcemia or kidney stones. That was a very important outcome also for both of these studies.
Well, one of my pet peeves with vitamin studies is that they rarely measure the levels of vitamins in the individuals. And I know it's hard to do that, and I know supplement companies don't want to do that. But, if you look at the meta-analysis, a lot of times these vitamin studies in a meta-analysis don't show benefits. And I think part of the reason for this is that there's not a lot of effort to optimize vitamin levels in the individual. So some people are taking too much, or they're already high and they take some and they go higher. Other people don't get up to the range. And so, I think it'll be really interesting if you can stratify who's responding and what the levels of vitamin D in the responders are compared to the levels in the non-responders.
So I think that's really another key point. Thank you for mentioning that, because we did this. We did not pre-select on vitamin D levels in Do Health, because we know we gave everybody a dose that would make them, if they are deficient, non-deficient. And we still measured, of course, the blood levels, and they increased. However, Brian, we saw the increase in blood levels is misleading, because also in the Sanders trial, all those trials that had detrimental effects, the 25-hydroxy-D increased beautifully. And we thought, wow, this is great. But then you saw the side effects. So if you, in fact, you need to measure the whole profile, also the countervailing factors, and have that complete assessment. But just measuring 25-hydroxy-D increase is not reflecting the true benefit, because of that bolus daily dosing.
One of the things I think that's exciting about your study is you saw additive effects. And I think you mentioned that you're trying to target different mechanisms, which is important. I'm kind of on a rant about people assuming that if they take 3 different supplements that have a benefit, if they combine them all together, they're going to get additive effects. Because in most of our animal studies, that's not the case. But I think what's interesting here is you intentionally targeted different pathways that should together be additive, as opposed to a lot of supplements which tend to target the same pathways, and targeting from too many different angles may not be good. So I think this is a good model for how to get to additivity.
Brian, thank you very much. I fully agree. And we sometimes targeting the same mechanisms. We are concerned about competing of these interventions. And in a way, for us, when we think about lifestyle, the additiveness of making small changes in several lifestyles is, of course, something we have a lot of hope in. But this is not the supplements. So if we think about supplements, we have just recently also on the positive side learned from the Cosmos trial that multivitamin, of course, having a whole combination of vitamins and minerals reduced the decline in cognitive function. And I think the research you are doing in Singapore is so key to really look at these different mechanisms and also interventions all the way down to the mechanisms at the mitochondrial function level. And yeah, I'm a big fan, Brian.
Thank you. Let's talk. I'll give you one question about biologic aging, and then we'll turn it over to the audience. You saw a significant effect on biologic age, and in a study this big, that's very important. And I think I'm interested to hear your thoughts on this, because our studies are finding that interventions that affect biologic age work better in people that are not aging particularly well. So their biologic age is starting out higher than their chronologic age. You chose sort of the worst group to look at this in because you chose the healthiest group. So do you think it's going to be generally true that in these kinds of interventions are going to work better in people that are not optimized for biologic age relative to people that are already doing really well?
So I completely agree. So we were really worried that we got funded for the healthiest subset in Do Health, and we still saw that signal. It was also interesting. The signal was stronger in this population among those who had a low omega-3 intake at baseline. So this triggered now the submission back to the Swiss National Foundation to really do the analysis in all 5 countries. And I would fully agree that we expect stronger benefits in those who are on a trajectory of accelerated aging. At the same time, when we think about motivating people who are still healthy to do something, that's a good signal to have, that they also benefit. We had also a phenotypic outcome signal like that in Do Health, that there was a stronger reduction in falls with omega-3 in individuals who were more active. So that was also,
It's interesting. So I could ask questions all day, but I think we should turn it over to the audience. I want to bring in Wang Jia Chu, who's a visiting research fellow at NUS School of Medicine, and she's here to moderate the Q&A.
Thank you, Professor Brian, for the kind instruction. I am a geriatric doctor from China, and it's truly an honor to be a part of this webinar today. I'd also like to express my sincere appreciation to Professor Heike for her insightful and inspiring presentation. We've received a lot of thoughtful questions from our audience, and I'd like to start by asking the first one. Given the impressive reduction in infections, immune diseases, and cancer mortality seen in the VITAL and Do Health studies, which of these findings do you think are most clinically relevant for guiding supplementation in general aging population, especially in Asia?
So this is an excellent question. So both studies did not happen in Asia, but I would say they are still relevant for a population age 50 and older. So this is very nice that in these 2 trials we addressed a younger population age 50 and older and a population age 70 and older. And regarding the relevance, I think the relevance is really reflected in the outcomes, the 3 metrics of aging, and that several chronic diseases were addressed by these scalable supplements. And very, very key if we think about using this finding at the public health level is that both trials took also great care about the safety in these two trials. And VITAL was a 5-year study, Do Health a 3-year study. So we have good safety data. And I would like to mention that if you now think about translating that to, to an individual use, please stay with the doses tested. Because, with everything that we take, dosing is really key also for supplements. So we also learned in a recent meta-analysis that if we go up with the daily dose of omega-3, we may also trigger atrial fibrillation. So we looked at that in both VITAL and in Do Health. And with the 1 gram per day, we did not see such a risk. So don't think this is now, a good thing and I take more. I think that would be not a good idea. Really stay with the tested doses. The same for vitamin D.
Thank you, Professor Heike. And the second question is also about the doses. The second question is, if a daily dose of 2000 IU of vitamin D is recommended for elderly individuals, would the same dosage be appropriate or necessary for younger adults as well? What is the age threshold at which a higher dose of vitamin D is required or recommended?
So here it really is important that we have guidelines on vitamin D, which are internationally addressing bone health, because at every age, vitamin D is important for bone health. But these doses are much lower. So for the first year in life, the 400 IU per day. Then if you're older, up to 65, it's 600 IU vitamin D. And we recommend in adults age 65 and older for bone health not to be D deficient, 800 IU per day. So the need for vitamin D increases with age when your goal is to prevent vitamin D deficiency. And we also know that people who are overweight will need more vitamin D, about 2 to 3 times the dose that we are recommending for a person who is not overweight to prevent D deficiency. Now, for the 2 studies that we just heard about, this is a new world. This is not about bone health, correcting vitamin D deficiency. This is really about influencing health span. And here the 2000 IU per day are now validated for adults age 50 and older and adults age 70 and older. And if you ask me, can I extrapolate that to younger individuals? I would say most likely, but we can't make that conclusion based on these 2 trials.
Thank you, Professor. And here we come to the third question. It's once an aging clock biomarker demonstrates predictive value, what do you see as the main steps and challenges towards integrating it into routine clinical or public health practice?
Another excellent question. So we have now many promising biomarkers of aging. We are very interested in the individual organ aging clocks and also the epigenetic clocks at this stage in the implementation in our healthy longevity clinic, but very much knowing that we have a good validation for risk. But what we really want to see is that these clocks respond to intervention. So for the epigenetic clocks, this is now promising based on our Do Health data for omega-3 and for telomere lengths in the VITAL study. But we also want to see that for the individual aging clocks by Tony Viscorai, which need that validation step, as most biomarkers of aging still do. And this is really key to then translate the findings into clinical care. Because we want to use these measures to also show what is the benefit of the recommendations we give. And in our longevity clinic, the concept is to integrate these measures in a learning system, also to further improve them, combine them, become more exact, and combined with a really good examination of all body functions, very similar to how you do this in Singapore.
Thank you, Professor. And there's a very specific question about the clinical trial you mentioned. This one audience want to ask, does the trial adjust for the participants' daily sunlight exposure?
So this was a randomized control trial, which gives you a lot of advantages because the by chance randomization, if you get the intervention or the control, balances all the other background information. So basically the randomization took care that we had the same amount of people with more or less sunshine exposure. We did not measure that, but at this size of a trial, you can expect that. And for other outcomes that were measured, we showed that randomization worked, that we really had a balanced baseline exposure of everything else but the treatment that we gave.
Thank you, Professor. And there's another question also asked about the clinical trials. He asked about, could you please elaborate more on exercise component? How was it designed and what specific aspects related to exercise were you focusing on?
So this is an excellent question. So this was really a very simple home-based exercise program, and the only tool being used was a TheraBand, which was, to train arm strength and also leg strength. There was a stepping exercise. There was one balance exercise, and we supported the exercise component with an avatar movie people could follow. But we also, in the end concluded that our very fit population would have needed a much more intense exercise program. But we were happy to see that for cancer prevention and also frailty prevention, it contributed to the combined benefit. So it was a very simple strength-based exercise program at home, 30 minutes, 3 times a week. And over 60% did it 2 times a week.
It sounds really nice, and we can practice at home. Okay, and here's a last question from myself. We all know that the implementation of multi-center clinical trial is extremely challenging. And in your opinion, what is the most helpful quality for this kind of work?
So I have to say, I probably don't have the energy anymore to do that again. So it was really, we learned that every country in Europe has different regulations. It was a major offer by a major effort by a great team. In each of these countries, we had top partners that helped this. But what was really, really key is the monitoring. So our team visited each site regularly, and we certified each study nurse, each study MD again and again to really keep that high quality standardization. And that was really key. And so it was a really interesting experience to health, and it worked because we had a great team.
Thanks a lot, Heike. And I think that if you take a little bit more vitamin D, you might be able to run another study. So keep that in mind. Maybe exercise, ramp it up a little bit.
Well, I try.
And thanks to you for the questions. That was great. I want to remind people to use the chat function and the panelists and all attendees option to leave comments and feedback on the show so we can pay attention to that. Also, just a reminder that the new webinar structure will be starting in August. As mentioned in the past, we will have past few episodes, we're evolving. So starting in August, we'll adopt a new format with just 2 shows every month, the first and third Thursday of the month, the same time at 7 p.m. So be sure and register for our latest schedule. That said, our next episode will follow this new format. So we'll see you on August 7th, where we'll have Nir Barzilai, who's like becoming a regular offender on this show. He hasn't given us his title yet, but I'm sure it will be really interesting and related to aging. And so for our final video to let you go, we're going to talk about a cat. You know, they say that cats or dogs have owners and cats have servants. So this cat is named Cream Puff. And surprisingly, Cream Puff worked with her servants to become the oldest cat ever recorded. You wouldn't think anything named Cream Puff could live a long time, but somehow this cat did it. So let's learn the secrets.
Now, we all know that cats have 9 lives, which already feels like 8 too many when you compare it to our meagre 1. But if a moggy can hang on to all of them and avoid their number 1 killers in curiosity and cars, they can often reach the lofty heights of 16 years old. Amazingly though, one cat has managed to live twice that amount. Hailing from Austin, Texas, the embarrassingly named Cream Puff lived to the ripe old age of 38 years and 3 days, and is officially the oldest cat to ever grace the earth.
He was real famous. I guess the word would be celebrity.
From her birth on the 3rd of August 1964 to her death on 6th of August 2005, Cream Puff lived through everything from the Apollo moon landings to the rise and ever so devastating fall of Atomic Kitten, who I can only presume were her favourite band. What's really strange about Cream Puff's story though is that her owner, a Mr. Jake Perry, was also the proud owner of the previously oldest cat in the world, a 34-year-old Tom by the name of Grandpa Rex Allen. So while Mr. Perry was certainly terrible at naming his cats,
Stephanie, Charlotte, Mittens, Mungo, Hopsine, Red Dog, Buffy the Vampire, Suzanne Rosanna.
there's no denying he's been incredibly good at taking care of them, which begs the question, just what on earth has he been doing? Well, turn away RSPCA if you're watching, as I've a feeling you may not like the answer. When it comes to diet, Mr. Perry feeds his cats an assortment of horrors, including cat food, broccoli, eggs, turkey, bacon, and coffee with cream, the latter being severely frowned upon by every veterinary professional in existence. To make things worse, Mr. Perry also claims to have given Cream Puff specifically around an eyedropper full of red wine twice a week to help circulate her arteries. In short, he fed his cats a seemingly lethal concoction of alcohol and caffeine, much to the dismay of the medical profession. Although it's brought him great success, we don't recommend trying the same for your own cat, as it's more likely to live all of 38 minutes rather than 38 years. However, you can't really knock Perry and his methods, as they seem to get results, and he's so far thought to have raised at least 6 cats to over the age of 30 years old. His home is now even something of a retirement centre for geriatric moggies, and he's even converted his garage into a home movie theatre for cats, which exclusively plays nature documentaries for them to enjoy. I guess all that's left to say is well done to Jake for all his hard work.
I'm feeling like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down.